Okay, so I've literally been called to the front to see a patient who has been having chest pain for the last 2.5 hours, and they don't have any chest pain at the moment. And I've been showing this ECG. We're shown to one of the SHOs, senior house officers, one of the junior doctors, and they looked at it and they were a bit concerned. So I'll put the ECG up here at some point now. They were concerned of these changes that you can see, which in most cases look like something that we call high takeoff, which can be absolutely normal. But the SHO did fantastically well by raising this to a senior doctor, and in this case it was me. I went to see the patient, and the patient actually, yes, they did have chest pain, and the chest pain is no longer there, but the changes in the ECG resemble a myocardial infarction, also known as a heart attack. So what I've done is I have actually discussed this patient with the cardiologist, a heart specialist doctor who's on call for the PCI, which is the coronary intervention, the cath lab. And very quickly the cardiology consultant has wanted to take this patient to the cath lab. So we took the patient there. Very quickly they got them onto the table and found that 2 vessels were actually blocked, the left circumflex and the left anterior descending artery, and you can clearly see that those changes are represented by the changes on the ECG. Now these changes on the ECG can also be in other cases seen as very normal, so this is why the importance of a detailed, thorough history, rapid assessment, and then instigating the correct management plan and talking to the right people in the specialist field. We're able to do very well, and we managed to get this patient within 10 minutes from the A&E, the emergency department, all the way to the cath lab with the cardiologist, open up those 2 vessels, prevent this patient from having a major heart attack that can cause serious complications. And yeah, fantastic job. Even the cardiologist said, excellent catch. So these are the types of cases that make our day, because someone who potentially was having something serious going on, we've prevented them from having a very serious complication. Alright, yeah, let's get back to work really. Let's get back to work. You're not going to believe literally what happened. Absolutely crazy story. Literally got a call to go to the front of the A&E department because we've got a patient who's delivering a baby. Now, my first thought was, you need to go to maternity, and problem was, the baby was already out, still attached with the cord. In between mum's legs, in a chair. So this was the first experience for me in all these years, so this was very interesting and very nice. So everybody was excited, but the most important thing was, mother's giving birth to baby outside in the cold, -2 outside. So we need to make sure this baby's not hypothermic. We need to make sure that we actually clamp and cut the cord, warm baby up, stimulate the baby, make sure that they're breathing and everything's okay. So essentially do a full assessment. So we've moved the baby into resus, dried the baby, kept them warm, clamped, cut the cord, put the baby onto the resuscitator. Baby's absolutely fine, mother's absolutely fine, absolutely brilliant. Fantastic. Yeah, actually very good news. I did tell them to name the baby after me, but we'll see whether they take that on board. But yeah, wonderful news. I don't think we're going to be able to top that. I think it's going to be pretty standard, so yeah, wonderful. And anyway, let's carry on. Okay, so we just got a call to resus. It's an older person who's had abdominal pain, back pain. They've had 2 episodes of collapse, and essentially we need to see what's going on, whether it's infection, an injury, a stroke, something to do with the heart, something to do with the blood vessels in they call the aorta, or it could be nothing. It could be a simple faint. We're not too sure. So let's go and see what it is. Okay, so he's got a little bit of pain in his abdomen. His observations are all absolutely fine. He's got a little bit of high blood pressure. So what we need to do is scan his abdomen and scan his aorta. His aorta is a big blood vessel that comes off the heart. It travels through the thorax into the abdomen, and it takes pretty much all the blood from your heart to different parts of the body. Now, in an older person, this could be one of the things that either balloons up, called an aneurysm, or it's something that could tear, called a dissection. Now, I don't think it's any of those things, but it's one of the most important things to check. They're not a common thing. They do occur, and we do see them often enough, but it's not a common thing to see on a day-to-day basis. But it's one of the things that we have to rule out. So let's go and get the ultrasound machine. Scanned his abdomen, and interestingly enough, I managed to find a aneurysm. Quite a large one, 7.5 centimeters, so that's pretty large, much larger than what is considered to be safe. So this potentially may be accounting for this gentleman's features. So he's stable, he's well, which means that we go for a CT scan, a CAT scan as it's known in some places. So we're going to take him, we're going to take all the equipment with us, and we're going to roll on down to CT, get this urgent scan. And I've already discussed with the vascular team, which is a specialist surgical team, and they also want to have the CAT scan to see if it's the aneurysm that's causing the problem, and if it's in a position that they can do something about it, depending on what type of technique that they might need to do. Depends on the image that we can see on the CT scan. So let's go for the scan. Okay, so we looked at the image for the CT scan, and what we can clearly see is that it is the aneurysm that is leaking. Luckily managed to self-seal itself, which is good, and hence why he's maintaining a good blood pressure. His blood pressure is a bit too high, so we need to stabilize it, bring it a little bit down. We don't want to dislodge the clot that's holding everything together. Unfortunately, the lower part of the image that I'm going to show you here, you can see that there's a dissection. It's actually split, so this person's got a dissection and an aneurysm at the same time. So it's very interesting, very rare to see this happen in the same patient and happen at the same time. So I've discussed it with the vascular specialist team. Unfortunately, this is not a type of pathology that they're going to be able to do something about, and therefore, with regret, you just have to keep the patient nice and stable, keep them comfortable, and look after them on the ward. Now, one of the very sad things about this condition is that unfortunately majority of people won't actually survive, and that's because at one point it's going to completely rupture. It already has, but it's stabilized at the moment, but it will rupture, and essentially it causes massive internal bleeding, and people don't survive from that. So when you're bleeding and you're pouring in blood products to try to help the person, you can only keep the blood going in if you stop what's coming out, like a leaking pipe. If it's going to come out the other end, you're essentially just pouring things in one end and it's coming out the other. So in these horrible situations, when the surgical team are not able to do a certain procedure, and there's many different reasons, it could be due to many different medical conditions that the patient has, and therefore it makes them very unsafe for an operation because they won't essentially survive the operation. Or it could be that certain procedures can't be done because of the size and the type of disease that is going on, and therefore it's not amenable to fixation. It's too far gone. And then when those tough decisions are made, then we have the chat with the family, the patient, and we walk them through these diagnosis and the plan and the reasons why we make these decisions. In essence, it's preserving the dignity of life, and it's one of the important things that most people don't talk about, is maintenance of dignity of life. But essentially, just because sometimes we can do something doesn't always mean it's the best thing. So yes, physically one can do the operation, but the outcome is still going to be very negative. It's only going to result in causing harm to the body and not maintaining dignity of life. So we're very grateful, and the family are very appreciative of honesty, and we always try to maintain honesty. We always say things up front and how they are, and families appreciate that, and we're grateful for their understanding in these difficult, tough times. And I don't think a lot of people get to see that in the emergency department looking from the outside. Yes, we're rushed around and we don't have a lot of time, but we do the best that we can, and we definitely like to maintain care, trust and dignity for all patients. That's why we're in the job, and that's why we do what we can do. So anyway, I think it's been quite a rough day, and you're probably all bored of hearing my voice, and it was interesting, lots of ups and downs. But this is essentially what it is in the ER, in the emergency department. A lot of interesting cases, some not so interesting cases, some difficult cases, stressful times, fun times, and this is what we do, and this is what we do every day. See you all in the next video. You look after yourselves and keep safe. Thanks for watching.